So yeah, I'll be presenting my work on acute myeloid leukemia, or AML. And leukemia research and precision medicine is a strong research focus here in the Hunter. And I just sort of wanted to start at the top with some acknowledgements. So we've formed a really strong collaborative research program spanning from basic scientists through to clinician researchers and clinical trial coordinators. And so I'm part of the basic science team pictured down the bottom here. And I wanted to acknowledge my talented research assistant, Casey, who's helped me with the data I'll present today. And she's partly funded by my Cure Cancer grant this year. And I also wanted to point out Sarah Lukeman at the top here, and she's an AML survivor, and she works with our team to make sure that we're working on projects that are relevant to patients' needs. So acute myeloid leukemia, or AML, is a really aggressive cancer that affects the bone marrow and the blood. So in AML, there's an increased proliferation and a decreased differentiation of myeloid progenitor cells. And so instead of a normal representation of healthy red and white cells, the bone marrow and the peripheral blood become overrun with these immature cells, and this impairs the normal function of the blood, leading to symptoms such as fatigue, easy bruising, and recurring infections. The standard of care for AML was established in the 1970s, where it was found that a chemotherapy regimen of cytarabine plus an anthracycline was an effective treatment strategy. However, this strategy is also highly toxic, and this precludes some patients from being able to receive it. The past decade has seen the additional approval of several targeted and low intensity therapies, including Venetoclax, midostaurin, and azacitidine. But due to the heterogeneity of AML, the response rates to these agents are quite diverse, and so overall survival rates are still low. And you can see over on the right that 5-year survival for AML is still well below the average for all cancers combined. So there have been a number of recurring mutations identified in AML, and these occur in signaling proteins, transcription factors, and epigenetic regulators. However, only around 50% of AML patients have clinically actionable gene mutations, so mutations for which there are therapies currently available. More than 50% of patients who do achieve a complete response to therapy will relapse, and once relapsed, there are few effective treatment options. So together, this means that we still need to identify better therapies, and to be able to do this, we need to be able to understand the pathways that are driving disease in individual patients. So to begin answering this question, we firstly looked at FLT3 mutant AML being the most common mutant subtype of AML, and also a poor prognosis subtype. So what is FLT3? It's the receptor tyrosine kinase. Its activity is normally regulated by its ligands, the FLT ligands. So binding of this ligand activates the receptor, and this leads to phosphorylation and activation of downstream growth and survival pathways, including MAPK, JAK-STAT, and PI3K. In AML, FLT3 is commonly activated by mutation. So these mutations constitutively activate the receptor, and that leads to constitutive activation of these downstream growth and survival pathways. Unfortunately, attempts to therapeutically inhibit FLT3 haven't proven successful as monotherapy in AML due to the development of drug resistance and disease relapse. So we reasoned that a better understanding of the oncogenic signaling pathways activated by mutant FLT3 is required to identify better therapeutic strategies. And as these signaling pathways are controlled by phosphorylation, a good way to look into this is to use mass spectrometry. So we went on to measure the phosphoproteomes of FLT3 mutant and FLT3 wild type AML patients, and I compared the signaling pathways that are activated in FLT3 mutant compared to wild type. And as expected, we found enrichment of pathways that are known to be involved in FLT3 signaling, so MAPK, PI3K, mTOR, and JAK-STAT, as I mentioned. But what we didn't expect was we found activation of DNA repair pathways, and in particular DNA PK dependent DNA repair pathways. So this led us to ask, could we target DNA PK therapeutically in FLT3 mutant AML? Could this be an effective treatment strategy? So we went on to test this in a FLT3 mutant mouse model of AML, where we treated mice with either vehicle, a DNA PK inhibitor alone, which we found wasn't effective to improve survival. Treatment with a FLT3 inhibitor alone provided some survival advantage, but the two in combination provided a significant survival advantage compared to all other treatment arms. And the DNA PK inhibitor we used, M3814, following this went into clinical trial in combination with chemotherapy in the US. But we'd really like to get it into clinical trial here as well in combination with further agents. And so the first step towards this was to test DNA PK inhibitors in combination with other standard of care agents to be used for AML. So to begin testing this, we used the FLT3 mutant cell line MV411, and we tested response to midostaurin, which is a multi-kinase inhibitor used for AML therapy. So this graph shows cell survival with increasing doses of midostaurin. We tested the DNA PK inhibitor M314, and from this, these results, we can calculate the expected effect of combining the two drugs, assuming an additive interaction. And the experimental result we found had a better than additive or a synergistic interaction by combining these two drugs, indicating that they combine effectively. We also went on to test azacitidine, another standard of care agent for AML, and we found a slight synergistic interaction. And lastly, we tested M3814 in combination with Venetoclax, and we saw quite a large synergistic interaction between these two drugs that we wanted to investigate further. So what is Venetoclax? It's an inhibitor of the pro-survival protein BCL2, and BCL2 is commonly overexpressed in AML, so this promotes cell survival. It follows then that inhibiting BCL2 with Venetoclax promotes cell death. So Venetoclax is proven effective and well tolerated by AML patients and received accelerated approval for treatment in 2018. However, due to drug resistance, unfortunately, only 40% of patients will achieve a long-term response to Venetoclax. And so this is where my Cure Cancer funded project comes in. We're going to be testing the hypothesis that DNA PK inhibitors will sensitize Venetoclax resistant cells to Venetoclax. And so to test this, we will be testing DNA PK inhibitors in combination with Venetoclax in preclinical models of AML, so patient samples, cell lines, and mouse models, with the aim of providing data to support future clinical trials. And so in preliminary data, I've tested the M314 DNA PK inhibitor combination with Venetoclax in a panel of human AML cell lines. So on the left here, we've got 3 Venetoclax sensitive lines with their response to Venetoclax shown in the gray. And on the right, 3 Venetoclax resistant lines. The response to M314 is shown in blue, and the combination in red. And so we saw a highly synergistic interaction between M314 and Venetoclax in our 3 Venetoclax resistant lines, bringing cell survival back down to the level of our Venetoclax sensitive lines. So in conclusion, quantitative phosphoproteomics can identify novel therapeutic targets, and DNA PK inhibitors are a promising novel strategy for AML treatment and for overcoming Venetoclax resistance. So this year I'll be looking at the mechanism of the synergy between DNA PK inhibitors and Venetoclax, and as I mentioned, performing preclinical testing. So I'd just like to thank everyone that's been involved in this project. I'd really like to thank Cure Cancer and the Bobbin Head Cruising Club for supporting my work. And I'd also really like to thank the patients and the donors and their families, without whom none of this would be possible.